Well, hello everybody.
Hello.
Thanks for coming today on a warm July day here in Wellesley. And this is a beautiful place. My first time here. This is fantastic. So really appreciate everybody from the Council of Aging having me. My name is Eugenio Candal. I am an ophthalmologist. I'm a board-certified ophthalmologist. I recently joined eye care and laser surgery here in Newton Wellesley. I've been practicing in Worcester for the last 20 years, and about a year ago I joined a practice here locally. So it's been great, and I live here in Newton. I'm local, so my commute has gotten much better. So I am happy to talk about cataracts today, and feel free to make this interactive. If you have any questions, feel free to interrupt, and I'm happy to answer anything I can. And I'd love to entertain any questions, and I'm happy to answer any other questions, comments, concerns. So let's get started. So cataract surgery, when to have it and what are your options? So we go down. Wanted to talk a little bit about the basic anatomy of the eye first, because a lot of us talk about cataracts, but first and foremost we should know a little bit about the eye itself. So if you look from the front to the back of the eye, the front is the cornea. The cornea is kind of like the window of the eye, and if your cornea is not clear, even if you don't have a cataract, you're not going to see well. So you always have to have a clear cornea. Behind the cornea is what gives us the color of the eye, called the iris. So when people talk about their color of the eye, it comes from the iris. And this is actually behind the cornea, which we don't see, which is transparent normally. Behind the iris comes the lens. The lens is what we're going to talk about today, mostly with cataract and cataract surgery. Behind the lens, again going back a little bit, you've got the vitreous, which makes up the majority of the eye. And the vitreous is kind of like a gel. It gives the eyeball its shape. And again, it's normally very clear. And this is where another entity that's quite common that we get, called vitreous floaters, develop. And we can talk about vitreous floaters another day, but this is also supposed to be nice and clear. And this allows the rays of light to get back here to the retina. The retina, I call it like the wallpaper of the eye. It's where the rays of light are supposed to land, and that later transmits information from the retina back here to the optic nerve. The optic nerve, I call it the cable that connects the eye to the brain, because ultimately the brain is where our vision forms. So you need to have all of these parts intact, as well as the optic nerve connecting that to our brain to have an intact visual function. So just a little bit to go in terms of the anatomy. Then here we've got common vision disorders, let's say. So again, what I want to point out here is that with normal vision, the rays of light come through the eye and they land on the retina. Perfect. Hyperopia is where what a lot of people call farsightedness. So what happens here, the rays of light don't land on the retina. They land theoretically behind the retina. So you actually have to have lenses to correct where the rays of light land, and they land on the retina once you get those lenses in front of your eyes. Down here we've got myopia, or nearsightedness. Nearsightedness is when technically the length of the eye is longer than average, and the rays of light, they land theoretically in front of the retina. So again, glasses will be needed to get the rays of light to land on the retina. And then we have here what's called astigmatism. What is astigmatism? A lot of people hear about astigmatism, but sometimes we don't really understand what that is. Astigmatism has to do with, part of it is the curvature of the cornea. What happens is that when the cornea, that clear part of the eye, is round, let's say like a soccer ball, the rays of light go in nice and parallel and they land on the retina, as we said. In people that have astigmatism, that cornea is more oval shaped, like a football. And the rays of light become more wavy and curvy, and vision becomes distorted. People get double vision, triple vision, and again, glasses will correct for that. So these are the most common vision disorders, so we can have a little bit of background here. So, getting to our topic of today, the crystalline lens, which is what we're going to talk about mostly. The normal crystalline lens, as we said, it's when we're born, is nice and clear. It allows the rays of light to land on through the retina, pass through the retina, and it allows us to see beautifully. Functions of the crystalline lens. So here we have one of the most important things that we have around the crystalline lens are these ciliary muscles. The ciliary muscles, when we're young, up until we're in our 40s, which I call young now because as we get older, we all get younger, right? So when we get older, these ciliary muscles start to lose their plasticity, and so what happens is that over time, the rays of light, they're not landing on the retina anymore. They cannot. Our ciliary muscles cannot constrict enough to get the rays of light to land on the retina. So ultimately, it's almost as if we're becoming farsighted. And so that's why when we're in our 40s, we get this what's called short arm syndrome. Our arms are not long enough to be able to see well. So here we have ciliary muscles contract, and so that's what normally happens. When we're young, we can get the muscles to constrict, and when we're looking at something close, we can come into focus. As we get older, we lose that ability. So, presbyopia. This is another very common term. Difficulty seeing close up. People notice that their eyes are sore, tired, and that happens a lot. That can also be a sign of dry eyes. That's something that we see a lot of in the clinic. But what happens is that people, when we're trying to struggle to see up close, we get headaches. That's called asthenopia. People tend to need more light as well. That can also be a sign related to cataracts. And people tend to notice that they need bigger font to be able to see up close. Again, presbyopia. So again, the image is not landing on the retina. Or that, and again, perfect compared to normal vision. So here we have an image which is the normal eye, again, and the lens with the cataract. The cataract here is basically an opacification of our natural lens. So what happens? Basically, the biochemistry is that there are these sulfa chains that become more prominent within the natural lens. And so instead of it being a nice crystalline lens, it becomes more like an almond, becomes darker. And so the rays of light are not getting into the eye, and that's why people tend to notice that they need more light, oncoming glare, halos, we'll talk about that, and are typical symptoms associated with cataracts. So here we see, normally this should be nice and clear, and here we're developing that opacification, that cataract. And here we have one of a very advanced cataract that, you would think in today's day and age we don't see many, but I saw one yesterday that is this color. And so these cataracts can sometimes develop very quickly. And so I tell people all the time, I've been called to the emergency room for cataracts, believe it or not. So it's not that they are from one day to the next, but what happens a lot of times is that the opacification affects the central portion of our vision sometimes very, very quickly. And that's when people notice it and they think it's an acute loss of vision, but it's actually related to a cataract. Babies can be born with cataracts. This a lot of times is due to different viruses, rubella, measles. So this is not very common. We don't see this very much these days. But that is definitely one of the possibilities that can be seen rarely in pediatrics. Diabetics, snowflake cataract. So what happens is that the blood sugar elevation will cause more prominence of these sulfa chains and an opacification within the natural lens, causing these spokes within our natural lens. So diabetics, higher incidence of cataracts at an earlier age. Even pre-diabetics sometimes get cataracts at an earlier age. Trauma. Here you can see this is what's called iridodialysis. The iris, the part of the gives us the color here, has been torn off because of trauma, and that has caused the opacification of our natural lens. And so that can happen very, very suddenly. That can be in a matter of days.
Wow.
So this is what's called a posterior subcapsular cataract. This is the back of the natural lens gets opaque. So people, for example, that are on certain medications, such as prednisone, sometimes diabetics can get these posterior subcapsular cataracts. And these are the kinds of cataracts that can come on quickly as well. And patients notice that their reading becomes really an issue, that they cannot focus because the central portion of their pupillary axis, their visual axis right here, is really impacted very early. So people tend to notice that right away, that they can't read, and it's quite sudden. People tend to notice it in a matter of months. We may be seeing them maybe very early, and then in a matter of months, people tend to notice it coming on very, very quickly. Symptoms of cataracts. So again, difficulty reading, glare from lights, frequent change in prescription from glasses. I tell people all the time, people ask, can I change my glasses? And I tell patients, yes, you could, but keep in mind that with your cataracts, if they are visually significant, the cataracts will cause you to have a change in your prescription again. So the typical example is that patients are, if they don't have any glasses, in our mid-40s, 50s, let's say, we're starting to use reading glasses. And then what happens is that over time, in our 60s and 70s, patients say, you know what, I used to wear reading glasses, but now I don't need them anymore. So why is that? Because the cataract is causing a change in your vision. It's what's called a myopic shift. You become more nearsighted. So people say, I can read now. Why is that? And it's because of the cataract that's developing. So some people call that second sight, or a myopic shift. So that's the other thing. I tell people that, again, beware, you can spend a lot of money on glasses, but how long will they last? 6 months, a year? You may come back in a year and say, you know what, I just bought these glasses, I still can't see well. And it's because of the cataract a lot of times. So poor night vision, that's probably the #1 complaint that we see patients with cataracts. What happens is that, again, you're not getting that light into the back of the eye. The rays of light are coming in like starbursts or halos. So patients notice a lot of times they don't feel comfortable driving at night because of the oncoming glare and halos from the headlights from the other cars. Faded colors. That's something that we see a lot after cataract surgery. Patients notice, especially between eyes, patients notice that one eye sees so much brighter, sharper, the colors are much more vibrant. And patients notice sometimes a sepia tone out of the eye that has not had surgery. So a big difference. Patients tend to notice that they're matching their clothes much better, or things are just more. The color of their house was different than they thought it was. So we've saved a lot of paint jobs in the house because of cataract surgery. So here we have it. Clear lenses, cataracts. Everything can look like halos. So especially with nighttime. Daytime, again, blurriness, haziness. Causes and risk factors. So diabetics, as we mentioned, that elevation in blood sugar, but also just spikes and changes in blood sugar will cause there to be a higher predominance of these sulfa chains in the natural lens, causing this opacification of our natural lens and leading to cataracts at an earlier age. With UV exposure, people that live closer to the equator, they are much more prone to get cataracts at an earlier age. So, and that's why we really stress to use sunglasses, especially in people that are closer to the equator. So it's very, very prominent. Not only, there's a bunch of things that can happen, obviously, with UV exposure in the eyes. Not only cataracts, people can sometimes get what are called pterygiae, which are these growths on the white of the eye, that first start in the white of the eye, the conjunctiva, and then grow onto the cornea because of ultraviolet exposure. Also, we also warn about UV exposure, lid lesions. So just putting a public service announcement, also very important to use sunglasses because of lid lesions. People that have squamous cell or basal cell cancers elsewhere we see lesions along the lid margin, upper and lower lids. So very important to use sunglasses. Tell people to make very good friends with sunglasses. Smoking, very important. We see smokers develop cataracts at a much earlier age. And not only cataracts, but also what can happen after cataract surgery is that when we do successful cataract surgery, we remove the natural lens and we leave behind our natural, what's called posterior capsule, to hold the new implant in place. People that smoke, that posterior capsule can become more opaque quickly. And then you need what's called a YAG capsulotomy, a laser to clear that up earlier because of smoking. So amongst other things, we could have a whole talk about smoking in the eye. Medications, very common with steroids, as we mentioned. Prednisone. Statins, we don't see that a lot, but it's been associated amiodarone, which is an antiarrhythmic, and some blood pressure medications, not very common as well. And I think that's more related to older medications at this point. Not very common these days with blood pressure medications. But I'd say the most common culprit here are steroids. Alcohol as well. Again, it's difficult to titrate alcohol intake and cataract formation, but it's definitely a risk factor. And birthdays, as we call it, right? As we get older, those birthdays don't come alone, as I like to say. So definitely one of the things that are associated with time are cataracts. So when to have it with cataract surgery? Cataract surgery should be done when it affects patients' activities of daily living significantly. Commonly, as we said, reading, especially driving in the evening, computer use, hobbies. Patients notice their gardening, their Wordle, things like that, that just when patients notice that they cannot function as well as they want to in their day-to-day, that would be the time to do surgery. Here we have, again, another example of glare or starbursts. So, cataract surgery. It's at this point, there's about 4 million cataract procedures done yearly in the United States. It's a 15-minute, usually, great majority of times, outpatient procedure. There are some states that are doing office-based, but I'd say in Massachusetts, probably 99% of cataract surgery is done in an ambulatory surgical center or a hospital. Hospitals, not that often anymore. Mostly ambulatory surgical centers. It's topical anesthesia the majority of the time. I'd say probably 90-95% of patients get done with topical anesthesia. The other alternative used to be more often to get a needle around the eye. We don't do that as much anymore because the drops are usually enough to keep things calm and usually pretty pain-free. The eye drops that we use an antibiotic. We use a topical, like an aspirin for the eye, an NSAID for 3 days before. And then we use those two plus a steroid drop for about 4 weeks after the surgery. You may hear there are some people that get what's called dropless cataract surgery. And so dropless cataract surgery is nice, but at the same time there's a percentage of people that get dropless cataract surgery that can have issues. For example, the eye pressure can sometimes go up in people that have these injections of steroids around the eye. And so also sometimes people that get dropless cataract surgery, even after a couple of weeks, the eye may still be not that comfortable, and a percentage of those patients still need drops. So we use drops for 3 days before and for about 4 weeks after the surgery. So the observation is, again, the alternative is to observe. Cataract surgery is elective surgery. I tell patients all the time, you never need to have cataract surgery unless patients are if there is a cataract that's so dense that can sometimes start to leak protein. It's very, very rare in today's day and age that you actually have a cataract that advanced. Or sometimes the cataract can become so dense that they can cause the pressure to go up in the eye, and that is really an indication to get the surgery done, because if you don't get it done, it's just going to get worse. But again, the majority of times, cataract surgery is elective. Again, where pain can be an indication of needing cataract surgery, as if there's a leakage, when there's a leakage of proteins in the eye. And so the denser the cataract gets, the higher the risk of intraoperative complications. So patients ask me all the time, can I wait? Yes. So I tell patients all the time, you can wait. And it's not an emergency. But keep in mind that glasses are not going to correct things, and that the cataracts will get thicker. And when they get thicker, what we use is laser so we use ultrasound and sometimes laser to remove the cataract. The issue is that the denser the cataract gets, you need more ultrasound energy to remove the cataract. And that higher need of ultrasound energy will cause delayed recovery, because that cornea, which you remember is the clear part of the eye, the window of the eye, that's what gets cloudy after the surgery. So it may take longer, the recovery will take longer in a cataract that is denser. So, and also, when we're using a lot of energy to remove a cataract that's very dense, there's a higher risk of the membrane that holds the cataract in place not staying intact. And if that were to happen, then the cataract or a piece of the cataract can sometimes fall towards the retina, and then you need another surgeon to go back and retrieve that piece of the cataract from the back of the eye. Again, that doesn't happen too often in this day and age, but it could happen. And statistically, the risks are greater the longer you wait the cataract to develop or mature. So again, the great majority of times we tell people that it's elective. Yes, go ahead.
Do cataracts grow back?
That's a great question. So the entirety of the cataract won't grow back, but what some people call secondary cataracts is that posterior capsule that becomes opacified. So that membrane that we leave behind on purpose to hold as a scaffold, as a support system for the new implant that we put in the eye, that has what are called lens epithelial cells that continue to replicate over time. And that can cause blurriness, fuzziness, haziness over time. And that may happen months or many, many years or decades later. And if that happens, we can fix that with that laser that we talked about before called a YAG capsulotomy. So that laser creates an opening in that capsule and that clears things up. So to your question, yes, the cataract does not grow back, but the membrane that holds the implant in place can get cloudy. And that's what we fix with the laser. Was there a question here? No. So yeah, so it's quite common that patients hear a secondary cataract. It's not that the cataract itself grows back, but that membrane gets cloudy. So how is it done? So at this point in the day and age, YouTube, you can see, iTube, you can see cataract surgery as much as you want on the internet. But basically, in a very short matter of explaining, we make a small incision. The emulsification here is basically the ultrasound. And so what happened was that, interestingly enough, the ophthalmologist that developed this took the idea from the dentist, actually. And they came up with a tip that moves very, very quickly, thousands of times a second, and it eats up the cataract, basically. It emulsifies the cataract. After that's done, we leave behind the membrane, the posterior capsule. We insert the intraocular lens, and the incision, that clear corneal incision, heals on its own 99% of the time. Rarely, if the incision does not appear to be self-sealing, we might need to put in a stitch. It's rare for that to happen these days. And if you do get a stitch, that stitch can stay in there. A lot of times we'll leave the stitch in for 3 or 4 weeks and then we remove it. But the majority of times, I'd say probably 99% of the time, we don't use any stitches.
You'd mentioned that the cornea, you're treating after the age surgery for 4 weeks because to treat the cornea. Is that to treat the hole, or is it to treat cloudiness of the whole cornea?
It's actually a very good question. So we're not treating the hole. It's actually the cloudiness of the cornea is one thing.
Yeah.
Exactly. Because what happens is that when there is surgery, there's inflammation. Our body responds by releasing proteins. And that protein can cause light sensitivity, discomfort, redness. And so the steroids, they reduce all that. So they treat the pain, they treat the light sensitivity, and it also reduces the swelling in your cornea. It's been shown that by giving the steroid drops and the aspirin drops, it reduces the swelling in the cornea. And also, very importantly, there's a small percentage of people that after cataract surgery can develop swelling in the back of the eye, in the retina. So these drops will reduce the risk of swelling in the retina because swelling in the retina can lead to loss of vision as well. So they're very important to use. Yes?
When do you normally use the laser for cataract surgery?
That's a great question. We're going to get to that.
Okay.
That's what we use laser assisted cataract surgery. I'd say about 2/3 of my patients are getting laser assisted cataract surgery these days, and we're going to go over that.
So you don't make the incision then, right?
So we actually still make an incision, but the nice thing about the laser is that the laser can actually create the opening in the anterior aspect of the lens. This is an abbreviated version of what we do with the cataract surgery. Part of the cataract surgery also involves removing the anterior aspect of the natural lens so we can emulsify the cataract. The laser does that for us. And it also, the nice thing about the laser, we're going to talk about as well, it creates a precise opening. So, benefits of the laser, exactly. So, risks. Again, I tell patients, 99% success rate overall. And I warn everybody, what the big 3 that can cause blindness: infection. The risk of infection is 1 in 1,000. Retinal detachment, about 1%. Bleeding, 1 in several tens of thousands, if not more. And again, like I tell everybody, there's a risk in getting in the car and driving over here today. Yeah. Things can rarely happen. But these are the things that can cause blindness, the big 3, I call them. So again, the risk of those things happening very, very low. Is that me? Oh, yeah. Okay. So again, the risk of those things happening are very, very low. So other things that we could talk about cataract complications for days, because things can rarely happen. For example, I also quote, there's less than a 1% chance there can be a cataract, a piece of the fragment of the cataract that gets stuck behind the iris, behind the pupil, and we don't see it. And so that can sometimes become apparent weeks after the surgery. Rare for that to happen, days or weeks afterwards. Sometimes patients get swelling in the eye, discomfort, loss of vision, and so that is a reason that rarely, again, less than 1%, we have to go back into the eye, remove that fragment in a 2-minute procedure, and that resolves the swelling in the eye and resolves the issue. Other things that can rarely happen, we talked about the secondary cataract. Some people call that a complication. It's not really a complication, I would say. It's something that happens quite often after cataract surgery. But again, inflammation. Patients can sometimes, people if they have brown colored eyes, sometimes the inflammation can last longer than a month. So I'd say there's about a 5% of my patients that, or less, that need drops longer than 4 weeks. But every eye is different, and you just never know how your eye is going to heal. So getting to, we talked about when to have the surgery and what are your options. So these are, as we said, when we're removing the cataract, you want to have a lens placed in your eye. So back when, my mom's ophthalmologist, back when she was doing cataract surgery back in the 80s, they used to remove the entirety of the lens. They would not leave that posterior capsule behind. And so they would remove the entirety of the lens. They would freeze it and take it out. And then patients would used to have to wear these Coke bottle glasses, super thick, to be able to see. So you actually want to have a lens inserted in your eye. Everybody gets a lens. I'd say, well, not everybody, but 99% of patients get a lens inserted in the eye. So the most common lens, and the first lens that came out, are what are called the monofocal lens. So monofocal. So this can be sometimes very confusing because there's what's called monofocal lenses, and then that's not to be confused with what's called monovision. So a monofocal lens, as the name implies, gives one focal distance. The great majority, I'd say probably 95% of my patients choose to see far away. What can happen with these lenses is, because these lenses come in half diopter increments, and because patients still may have astigmatism, which has to do with the curvature of the eye, patients may still need glasses at all times. So for far away and for up close. And again, you may talk to your friends and say, you know what, my friend John down the street had cataract surgery, he doesn't use glasses anymore. It ultimately depends on what their correction was before the surgery. Do they have astigmatism? Don't they have astigmatism? What kind of lens did they choose? Did they get laser-assisted cataract surgery? All those things are a consideration as to if they're going to need glasses or not after the surgery. So another kind of lens has to do with what's called astigmatism correction, or toric lenses. So the toric lenses, they have one focal distance as well. Usually, again, patients choose for far away. And with that, they will still need reading glasses, and I tell patients they'll still need glasses for the computer. So ultimately, when we talk about vision, pre and post surgery, we talk about distance vision, we talk about computer vision these days, which is so common, and near vision. There is a difference. Near vision is about 12 to 14 inches, computer vision is about 18 to 24 inches, and distance is considered anything past that. So I tell patients that if they are choosing a toric lens to correct for the astigmatism, their distance should end up pretty good, but they will still need glasses for the computer and for up close.
And what about for astigmatism? What happens with the torics?
So that will get treated with the toric lenses. So what we do with the toric lenses, so astigmatism has to be corrected by inserting the lens, and we position it in a certain axis to reduce the astigmatism. So with that, with the toric lenses, comes a risk, obviously, that the lens could slightly move. It may not stay in the exact location. That can sometimes, rarely, induce astigmatism, cause astigmatism, which would be a need for glasses, or undercorrect the astigmatism. So glasses may still sometimes be needed. We may not get rid of the entirety of the astigmatism. There are patients that have so much astigmatism that these lenses just cannot correct for the astigmatism. So I have patients that we max out the correction with our current lenses, and they still need some degree of glasses, but they're still seeing tremendously better. It's just that with our technology, in today's day and age, there's only so much that we can do right now. So those are toric lenses, correcting for astigmatism. Now, these are lenses called multifocal lenses. So multifocal lenses, these are one of the newer varieties in ophthalmology that have come out probably over the last 20, 25 years or so. So the multifocal lenses, I'd say we say that they do it all, mostly. So they correct for astigmatism, they correct for distance, intermediate, and near vision. So what I call these lenses, I call them 80% lenses. Statistically, patients can see about 80% of the day with less need for glasses. Because as I like to say, there's no perfect lens. These lenses are very good, but even with the multifocal lenses, patients can still need glasses from time to time. And so why is that? Because sometimes it depends on how the lens lies in the eye. There is this issue called effective lens position that neither the patient nor the surgeon has control over as to where the lens lies in the eye. And even though our calculations are quite good these days, there can still be slight discrepancies between what we measure and what happens with the surgery, causing a residual need for glasses. Now, these lenses are very good, but you can see here that the way that they get us to see far away, intermediate, and near is with these different rings of power, we call them. These rings of power have side effects, and potentially. The great majority of people are very happy, but they can sometimes induce issues with vision. And again, that's why I like to say no lens is perfect. Every lens has its trade-offs. So one of the newer kids on the block here is called the Vivity lens, or an extended depth of focus lens. So these also correct for astigmatism. They correct for the distance and the intermediate. But this lens, and this is not a great image because it should be only 2 of these circles, these lenses don't give you the near vision. So why would people choose the Vivity lens compared to the multifocal lens? Patients with the Vivity lens, they don't get the circles around headlights when they're driving at night. So my Uber drivers, my truck drivers, patients that are on the road a lot, my grandparents or parents that have to be on the road with their kids at camp or getting them to extracurricular activities in the evening, and they're concerned about nighttime driving, they are the ones that we think they'd be better candidates for the Vivity lens. That being said, they need to be aware, we try to make it very clear that they're still going to need reading glasses. So usually it's an over-the-counter pair of +1 that you buy at any pharmacy, but they will still need a small degree of reading glasses. So they plan on wearing a small degree of reading glasses.
And computer glasses as well?
Usually not. So with this lens, they're usually pretty good for intermediate. So again, it depends on, the majority of people are very good at distance and using the computer without glasses after this lens. There are some people that still notice that they still need a small prescription for the computer. But because there still may be a little bit of astigmatism, and there still may be some correction that still may be needed. But the great majority of people with these lenses can function to drive, let's say, and read the dashboard, watch TV, and use their computer. But if they're going to be on their phone, or if they're going to be doing an extended amount of reading, they're going to need a +1, +125 pair of over-the-counter cheaters. So getting to the gentleman's point about femto laser assisted cataract surgery. So the laser is something that's been done over the last several years, which has been a big advance, and it's become more and more popular, and patients are choosing it more and more these days. And I think it has to do with the fact that we like precision associated with the laser, and I think that, yes, the precision associated with the laser, the recovery time, and it treats astigmatism. So the issue is that what I tell patients is that when I've done thousands of cataract surgeries without the laser, and what we do is we create an opening in the anterior aspect of the lens, and I've done that manually thousands of times. However, things can rarely happen. Patients can move. It may be that there may be forces within the eye that cause the opening to steer out somewhat. And so that can sometimes affect the position of the new lens in the eye. So the nice thing about the laser is that the laser as long as patients are usually pretty good about staying still when we're doing the laser, that takes about 15 seconds, the laser will create a precise opening within the pupil. And that provides stability of where the new lens lies in the eye. And then the other benefit of the laser is that the laser can be programmed to pre-cut the cataract. So by the laser applying energy to the cataract, it reduces the amount of ultrasound energy that's needed to remove the cataract. And what's the benefit there? Less ultrasound, as we said in the case of the dense cataracts, less ultrasound ultimately results in quicker recovery because your cornea is not as beat up from the surgery. It's not as cloudy. So that's the benefit of the laser. So, and also, it can, so with the laser, if the multifocal lens or the Vivity lens cannot correct all the astigmatism, the laser can also improve the outcome by reducing the astigmatism even more, which is nice. Another newer lens. These are called light adjustable lenses you might have read about. The surgery is the same with these lenses. The issue with these lenses is that the final prescription is adjusted during the postoperative period. And it requires usually about 3 sessions. So these are getting better, and a lot of people, we don't do these at my practice right now. There are some people in the area that are doing light adjustable lenses. The issue with light adjustable lenses is that, again, it's the time, right? It takes several sessions after the surgery to get that prescription locked in. But it does seem to provide very good vision afterwards. And some patients are really happy with the quality of the vision because they don't get those halos that can sometimes be associated with these other lenses. Patients can see usually pretty well, distance and up close with these lenses. It's kind of like what's called a modified monovision. So the monovision, not to be compared with monofocal lens, monovision is when one eye sees in the distance. Usually the dominant eye is aimed for distance and the non-dominant eye is aimed for up close. It's usually not a huge discrepancy between the eyes with these lenses. But the great majority of people are very, very happy with these lenses as well. It's just that these are even more expensive than these other lenses, and it's the time that's needed a lot of times. And also, patients have to wear sunglasses usually for several weeks afterwards to protect them against ultraviolet exposure. So it is a process. It is getting better. Like everything I tell patients, that lenses are like iPhones. They're always getting better. But again, there's no perfect lens. That's what I stress to patients. Recovery after cataract surgery. Again, we said the drops for about a month. 3 days before and for 4 weeks afterwards, we use the drops. No heavy lifting, nothing over 25 pounds for about 2 weeks. Sorry about the typo, after surgery. I tell patients I don't want them to become deconditioned because of this. So brisk walking is fine. The stationary bike is fine as long as our head stays straight. I don't advise any yoga. Nothing that's going to be on the floor, those kinds of things, because we don't want the lens to shift in the eye. So that's the main thing. No swimming, nothing, we don't want the beach necessarily, going into the ocean for a couple weeks after the surgery as well. Patients can fly. Yep, patients can fly. Was that the question? Yep, patients can fly. No restriction there. So it's different from retina surgery. And so I am happy to open it up to questions at this point. Yes?
Can you talk at all about cost, options, and Medicare insurance?
Sure. So in terms of what's covered by insurance, so the lenses that we do that are called the monofocal lenses are the ones that are covered by insurance. So the monofocal lenses, that surgery is covered by insurance. As long as your vision qualifies you to get surgery, and that's the thing that we talk about, right? Because not everybody necessarily qualifies to get surgery. You have to have a certain level of vision, at least 20/40 or less with glare, to be able to qualify for cataract surgery. So I see a lot of patients that may have 20/25, 20/30 vision, because vision, let's get back to what numbers are. 20/20 is optimal vision. The higher the number, the worse the vision. You have to have at least 20/40 or worse with glare. Those are the Medicare guidelines to qualify for cataract surgery. And with that, the monofocal lenses, everything's covered by insurance. Again,
Including laser?
no. So the monofocal lens. So that's covered by insurance. So if you get the monofocal lens, and that's again, I try to stress that with the monofocal lens, chances are that patients see much better, clearer, sharper, but plan on wearing glasses. Possibly all of the time. That's with the monofocal lens. the next step up is what we call laser-assisted cataract surgery. In our practice, and this is, again, not covered by insurance. In our practice, our practice charges $1,750 per eye for what's called laser-assisted cataract surgery with a monofocal lens. So again, with the monofocal lens, even with laser, chances are we can correct for the astigmatism. As I said, the distance vision should end up pretty good, depending on the amount of astigmatism that's needed to be corrected. But patients still plan on wearing glasses for the computer and for up close. That's called laser-assisted cataract surgery.
Are you just speaking to Medicare coverage or private insurance as well?
So all insurances. This is yeah. So no insurance will cover anything except the monofocal lens. No insurance will cover, unfortunately, the laser or the multifocal or the light adjustable lens or the Vivity lens.
Will Medicare cover part of the cost that they would have paid if it was a monofocal lens? No?
No insurance will cover, not only Medicare, no private insurance either will cover anything that's not the monofocal lens. And the theory we think is that CMS basically thinks that allowing us to have more than just distance vision is considered kind of like cosmetic, and they don't cover, thus to give us the ability to see for the computer and up close. That may change, but I highly doubt it. Yes?
Are you principally referring to monofocal toric lens?
So no. So just plain monofocal. What's covered by insurance are plain monofocal lenses. So that's the basic monofocal lens that's covered by insurance. So laser-assisted cataract surgery is the next step up, and that is also with a monofocal lens. Now, and that's again $1,750 per eye in our practice. Then after that comes if you did want to get laser-assisted cataract surgery with a toric lens. Anything that is not a monofocal lens, we do include the laser because we do think that's very helpful. So the toric lenses are $2,900 per eye in our practice, and that includes everything again associated with laser-assisted cataract surgery is the monofocal lens, the toric lens again that corrects for astigmatism, and then after that comes what are called the multifocal or the Vivity lenses, and those are $3,950 per eye. And again, those include laser-assisted cataract surgery. Sure.
Hi.
Sure.
I have a recent diagnosis of being legally blind. Would cataract surgery be a help?
It depends on what the cause is. Did they say that it was the cataracts that were causing it?
No.
So if it's not the cataracts, then unfortunately, even if you had cataract surgery, the vision may not improve too much because it depends on what's happening with the retina and with the optic nerve. Because I tell patients that sometimes a cataract's like a car, right? You can if you have the shape of a car, you can replace the windshield, but if the motor's not running too well, the car's not going to run too well. Same thing with the cataract. You can replace the lens, but if the back of the eye is not running well, not functioning well, by replacing your natural lens, you're still not going to see better, unfortunately. So that's my concern that...
Okay, if I come to you for an exam,
Sure.
Can I find out?
Of course.
Okay,
I'd be happy to.
good. Do you have a card?
I do. I happen to have one right here.
Thank
If you do one eye, do you typically do the second eye within a
Good question.
if one is worse?
Yes, so usually we start with the eye that sees worse, and usually anywhere between 2 and 4 weeks later, we do the second eye. And so that is something that we talk about because it depends, that's something that can be critical in terms of, how patients are working these days, what their day-to-day is afterwards, if they have to go back to work, and in terms of the discrepancy between the eyes. Because let's say somebody's very nearsighted, that's a case where we probably want to shorten the amount of time between the eyes. Why? Because that depth perception is off until you get that second eye done. So that's something that patients can, really have to be aware of. That time in between the eyes can be a concern. We try to make it anywhere between 2 and 4 weeks. Some states in Florida, they do it the day after. In certain, and actually some states, they'll do simultaneous bilateral cataract surgery. Massachusetts, I think we're kind of conservative still. I don't think there's anybody in Mass that's doing simultaneous bilateral cataract surgery in Massachusetts. But usually we try to make it 2 to 4 weeks, and usually patients are pretty good. By that time, the great majority of patients after the second week, they're noticing that things are much better and they want to get the second eye done. Shoot.
May I say that I had my second cataract surgery this past Monday. Not that this fine, doctor.
Oh, I hope it went well.
It went well.
Great.
But I would want to emphasize that, as you just said, depth perception in between, my first was 3 weeks ago. Depth perception, if you have any vestibular issue, any balance issue, be alert to that. It will affect stability. And my surgeon doctor cautioned me, so I just wish to emphasize that point.
Great point.
It's not a deterrent, it's simply a consideration to bear in mind.
Great point. It is something that we talk about, and especially with the monovision, the small percentage of people that choose monovision. You did?
With toric, yeah.
You with the toric monovision?
Yeah.
So yeah, that is something that it can also cause a little bit of imbalance. Unless, if people have it and they're used to it, then I'd say yes, go for the monovision. But in patients that are not used to monovision, that can definitely cause some imbalance. And so it is something to keep in mind. I'd say probably 95% of my patients choose symmetry with their vision, usually for distance. But patients that like monovision, having their dominant eye for distance and non-dominant eye for up close, and they're used to that because they've worn contacts like that, or haven't worn glasses like that because they were just naturally happened, then those patients are very happy with monovision.
I have worn bifocals for my entire vision life, or so to speak, since the glasses. Reports go through.
Good to know, good to know. Yes, sorry.
I have two questions.
Sure.
First one, when you're talking about 20/30, 20/40,
Yes.
that's uncorrected, right? That's with no glasses on.
Depends.
Right.
So actually, no, even, you mean to qualify for
yes.
cataract surgery? No, it's actually what's called best corrected vision.
Correct. Oh,
Best corrected, so even with glasses.
Okay. And then the other question is, when you're talking about, well, you still might need glasses for computer and reading. I would believe you could still get a transition, progressive lens, clear on top, computer reading, right? So
Exactly.
if you're used to wearing glasses all the time, the top would just be
Clear. Exactly. So I tell the patients that, again, with these lenses, and the main thing that I stress, no lens is perfect.
Yeah.
So every lens has its trade-offs, and with these lenses that, again, can be very expensive, we still can expect to wear glasses from time to time. That being said, as long as expectations are realistic, usually patients are quite happy. But again, as long as the surgery goes well, and the great majority of times it does go well, everything should be correctable with glasses, as long as there's no issues in the back of the eye or no complications occur.
You said there were some side effects with the multifocal. What are some of those side effects?
So, great question. The multifocal lens, it has these what are called rings. So the nature of the lens is that it creates a different zones of vision because of those rings that allow patients to see distance, intermediate, and near. So the issue with those rings is that patients can sometimes notice halos, circles around headlights, especially with nighttime driving. That's something that is rare for it to become significant or significantly bothersome, but some people notice them. If you look at the odds, 70% of patients that get the multifocal lenses are not bothered by the rings or the halos. I'd say about 30% of patients notice the halos, less than 5% are bothered, and the statistic I quote is that there's about a 1 in 300 chance or less that you may not like the multifocal lens so much that you may want to consider having the lens exchanged or removed because of the quality of the vision. Again, very rare, knock on wood, I've never had any of my patients have that, but it can happen. And so rarely patients notice that with these lenses, what happens is that these lenses, they split the rays of light. So sometimes at first, patients can notice that their vision is a little bit washed out with these multifocal lenses. It's just not as crisp sometimes. That being said, if you look at the statistics, amongst the 12% of people that have severe halos with these lenses, 99% of those patients on retrospective survey would still have that lens inserted. So they will still like and enjoy the 80% of the day independence that they have of using glasses with these lenses.
But the monofocal corrects the halos and the glare. at night.
So with a monofocal lens, you're not splitting the rays of light. So that is the lens that will give you one distance. So exactly, it's going to give you the best possible vision in the distance as long as there's no residual astigmatism. If you have astigmatism, then the monofocal toric lens will correct that. It depends on how much astigmatism you have, and that's one of the things that patients that are unhappy or let's say underwhelmed with cataract surgery with their vision because they chose the monofocal, it's because of the residual astigmatism. So they still need glasses to correct for that.
If you're correcting the distance, does it make the close worse, or is it the way it was before?
It depends on what you were. So it depends on, for example, if patients are nearsighted
Right.
before the surgery and they choose to see better for far,
Right.
then they automatically lose the ability to see up close without glasses. So that's a big thing. I'll tell patients, you know, you're not going to be able to see up close. Put in your contact potentially, put in your makeup, things like that that are important. People see their puzzles, things like that. They may lose that right away. So, but the trade-off is that they'll see better from far. So their driving will be much better. Their TV will be much better. They'll go into the room and see the faces of people that they know much quicker, and they feel better on the road driving at night, especially. But some people, they're jewelers or people that knit a lot, that they want to be able to see up close, and they're 12 hours a day seeing up close. They want to be able to see up close better, and they choose to have the monofocal lens further up close
They're
vision.
giving up the distance.
Exactly.
So you're giving up one.
If you
to
choose,
correct the other.
exactly.
And if you do the one that one eye was near, one eye was far, are there balance issues with that?
If you're not used to it, there can be. So that's why I tell people, if you have not had monovision, which is different from the monofocal lens, if you have not had monovision, we put patients in a contact lens trial to see if they like it. Because we don't want to start with surgery, having patients start with that and then not like it.
I would say that's a balance.
Yes. So that's why if patients have not had monovision before, we don't start at the time of surgery. We want to make sure that patients like monovision before we do that with surgery. Shoot.
Yes, you mentioned the vivid lens. Is that correct for astigmatism?
Can, yes, definitely. So the multifocals and the vivides, they will correct for astigmatism. They come in varieties that we can position the lens within the eye to reduce the astigmatism.
And does that give you a close-up vision or just this?
So the Vivity, again, will give you the distance and the intermediate. Plan on wearing a pair of over-the-counter cheaters with the Vivity. The multifocal will give you the distance, intermediate, and near, as well as correct for the astigmatism. But therein comes the small risk of halos.
With the Vivity lens, you don't have the halos?
Correct. So the nighttime driving is potentially better with that Vivity, but you're not getting the up-close vision. So I summarize it saying the Vivity is kind of like a double negative. You don't get the near, but you don't get the halos. The multifocal, you get the near, but you can potentially get the halos.
I'm myopic, so I don't want to lose this because
So that's, yeah.
I take my glasses off from
Yes. So
it'll be reversed.
Myopes, low myopes, are kind of the trickiest patients because no lens that we put in the eye will ever give you your up-close vision as good as you have now.
Right.
You will never like anything that we put in the eye as good as what you have now. It'll give you pretty good, but it's not perfect. It's not going to give you what you have now.
But you have better distance.
Correct. Exactly. But the key is there's no perfect lens.
Yeah.
Can you develop a cataract in one eye as
Yes.
opposed to the other and not ever have it in the other eye?
Unlikely that would never happen. So I tell patients that if we live long enough, we all develop cataracts to a certain extent. My mom's 90, she hasn't had surgery for cataracts, but a lot of us, over time, she does have some incipient cataracts. And incipient cataracts can occur at age 40, 50, 60. So, and they can occur at different paces as well.
What is
So
that? What is it, incipient?
very early. So it could be that, I've had patients that have had a multifocal lens and then they come back 4 years later for the second eye to get their multifocal lens. So it ultimately depends. And patients after one eye, for example, they're really bothered by one eye and then they're very happy and they don't want to get the second eye done for months or years later. It
And your
happens.
vision is really different in the two eyes, isn't it?
Correct, it could be. But some patients are not bothered. So it ultimately depends because what happens may happen. So it may happen that what gets corrected is the dominant eye for far,
Yeah.
and so patients may be very happy with that.
But then you can't you still have the condition of the other eye.
Potentially,
before.
if there's a cataract. Yeah, if there's a cataract, I'd say the great majority of my patients, again, after a couple of weeks, they are ready to get the second eye done because they're noticing a big difference. They're noticing that, and you can probably attest to that the difference in terms of clarity, quality of vision, brightness, colors, nighttime driving becomes noticeable after a week or two, if not
I
sooner.
also suggest daytime driving too.
Great.
The color of the trees, the ground, the birds.
Excellent. Excellent.
Do
Yes.
they still grade them as, like, when you go, this is like 1 to 3 or 1 to 5?
Correct. We normally do 1 to 4
1 to 4. Okay.
in our practice.
4 being bad.
Severe.
Yeah.
Correct. So usually by the time cataracts are grade 2, they're kind of getting to the point that they're pretty ready.
Okay.
Yes.
Do the ciliary muscles still work, and do they work on the lenses?
That's a great question. So there was a lens that was more prominent maybe 15, 20 years ago called an accommodating lens that they used to insert in the eye. And so the thinking there was that the ciliary muscle could still have some ability to bring the vision into focus. It's been shown that these accommodating lenses that we inserted at that time, I didn't thankfully, but they're not really very helpful. They don't really last that long, and their effect kind of peters out over time. So the ciliary muscle, basically after you get the cataract surgery done, it's gone. So it's not going to give you the ability to see up close anymore. So it's basically, that's why if you get the monofocal lens to see better in the distance, you automatically need reading glasses. Yes?
My understanding of astigmatism is that the surface of the lens is irregular. When you put in a lens to correct that, how can you personalize it, because your structure is going to be different from other people?
So that's a good question. So actually, with astigmatism, you actually have different types of astigmatism. You have what's called corneal astigmatism, which has to do with the curvature of your eye, and you also have what's called lenticular astigmatism. So the lens, our natural lens, can sometimes induce astigmatism. So what we measure before we do cataract surgery is we measure the length of the eye, what's called the axial length, and the curvature of your cornea. Based on those measurements, we calculate the best power of the lens that's suited to you. And also, the calculations will give us where we want to insert the lens to what axis in your eye to reduce your astigmatism. And so what the risk there is, sometimes, again, I warn people that the lens can sometimes shift or move. Usually, the lenses that we use, they're called Alcon lenses, their stability is quite good. Probably 93 to 95% chance that the lens will not shift afterwards.
And there's a range of correction in those lenses?
Correct. So we call them from T1 to T9. T9 is the greatest amount of astigmatism that can be corrected. But even still, patients still have sometimes even more astigmatism that can be corrected. So there still can be patients that even with a T9, there still is residual astigmatism that needs to be corrected with glasses. But yes, that's a great point. We insert the lens, position it to a certain degree in a certain axis to reduce the astigmatism. Great point.
Fascinating.
Yes?
Have you found that your patients have been happy with the Vivity lens?
I'd say the great majority of patients, as long as their expectations are realistic, and I try to make it very realistic with the expectations, that yes, that their distance and their intermediate, they're quite good, they're quite happy. And the nice thing is, again, their nighttime driving is very good. It may not be as good as a monofocal for distance, but that expanded range of vision, patients really like it. And so, and a lot of, interestingly enough, even though we warn people to wear, that they will need reading glasses, there's a percentage of people that do quite well with the Vivity that actually can function most of the time to see their phone pretty well, even without glasses, sometimes. So it's a small percentage of people, but some people with the Vivity do quite well, even for some near vision. But I tell patients to plan on wearing reading glasses.
Yeah, trying to decide between those, the multifocal and the Vivities, kind of.
Yes, it can be a tough choice. And so ultimately, I tell people it depends on lifestyle, depends on personality. So I tell people that if there is something that if was off slightly with the vision, how much would that bother people? Because the issue is that If you're the kind of person that something is slightly off and that would tremendously bother you, then don't get the multifocal, because it's not worth that small risk. That being said, the chance of that happening is quite low. Again, as I told you before, that one study, amongst the 12% of people that notice the severe halos, 99% would still get the multifocal inserted. From a personal perspective, my father-in-law, he lives in rural Michigan, and he had the multifocal lens. He's a golfer and he's a reader. He loves it. And so it ultimately, you know, he's not doing a lot of nighttime driving in rural Michigan, but he loves this lens. My uncle, who's a retired OBGYN, he had a much older version of the multifocal. He's 85 now, and he's loving it. He still doesn't wear glasses.
Really?
And so his version was a lot stronger, so he actually has to bring things much closer to read. Now they've actually evolved. Again, they're always getting better.
Well, one question I had is, any lens better for like sports, like golf or tennis, like your golf or tennis?
Yes, so in general, again, depending on lifestyle, the Vivity or the multifocal is the way to go with these lenses, because they will give you that expanded range of vision. Ultimately, it depends on, a lot of times, nighttime driving. How much nighttime driving is there? Because that's where you might notice the circles, the halos. And again, over time, so I went to a conference last year where patients that small percentage of people that were not happy with the multifocal lenses, they did functional MRIs on those patients. And at first, the functional MRIs light up everywhere because patients are really bothered by their vision. Over time, 3 months, 6 months, a year, patients tend to neuroadapt. Their brain tends to adapt to these lenses. And they get used to having that new kind of vision. And then they like the fact that they can function most of the time. At this point, I've had many of my patients that are coming out years later that are still having with these multifocal lenses, and they're very happy. The Vivity has been out for 4 or 5 years, and they're also quite happy. But again, there's a higher percentage of patients that need reading glasses with that lens. And again, over time, things shift, things change. Not a huge amount. There's not a huge change in astigmatism over time, but there is what's called an astigmatic drift of 0.1, 0.2 diopters of astigmatism over years or decades. So a small prescription over time, 10, 15, 20 years, may still be needed afterwards. Yes?
I had floaters, and then I got the glasses on, and they're bifocals, and my eyes have settled down.
Great.
I don't go to see doctors anymore, or even have my eyes checked.
Okay.
I guess years on your life helps your eyes.
Well, I tell people, I'm glad that you're not noticing the floaters anymore. I do recommend the American Academy of Ophthalmology does recommend an annual eye exam for everyone over the age of 65. Why is that? Because over time, we can develop things like macular degeneration, glaucoma, and a lot of times, glaucoma is a condition that, we were talking with Kevin at some point, we might want to come back and talk about another time. But glaucoma is a condition, they call it the secret thief of vision. We can actually lose vision, 40% of our visual field, and not even notice it. So it is something that we need to check for and we screen for when you're in the office. So I'm glad you're doing well, but an annual eye exam is usually a good idea. And one thing that I do tell people that after cataract surgery, if patients have floaters before the surgery, sometimes after cataract surgery they become more prominent. And it's not that the cataract surgery causes the floaters, but by removing that opacification, those floaters can sometimes become more prominent. So patients can sometimes notice them more.
Interesting.
The other thing that I tell patients ahead of time with cataract surgery is dry eyes, another topic that we talk about frequently. Dry eyes is something that can become more prominent temporarily after cataract surgery. Oh, wow. We think it's related to the drops that we use, and the insult of these preservatives and these eye drops can dry out our eyes. That being said, over time, our eyes usually bounce back, our corneas usually bounce back, and they feel much better. But a lot of patients immediately after cataract surgery, during the first several weeks, they notice that their eyes are feeling irritated, burning, stinging. It's from the dryness, very likely from the eye drops. So I warn people about dry eyes.
No, so I have a friend who had the surgery where it's adjusted after the fact.
Yeah.
He said that's not common in Massachusetts.
Well, it's becoming more common. I'd say it's probably one of the least performed of the not covered by insurance techniques.
Okay.
But I think it's becoming more and more popular over time, slowly.
We seem to be very happy with
Yeah.
it. So,
What was that we didn't?
the other question I had is, can we get a copy of your presentation?
Sure, we can talk to Kevin about that. If how to get that out, we can print that out, I'm sure.
Sure.
Yeah. Happy to.
Great.
Sure.
Probably one or two more questions.
Yeah. Any other questions? Yes.
Now, there appears to be a difference between reading off a print page and reading the same font size on your cell phone. So, when you go for the surgery for the monos or one, do you end up improving any one of those two things?
Well, so it depends. So if you get the monofocal lens to see, it depends on where you choose to see. So if you choose the monofocal lens to see better for far away, unfortunately you're still going to need glasses for the computer and for up close. So your distance will be pretty good. Depending on the amount of astigmatism you have, your distance will be pretty good, but you're still going to need glasses. So regardless of the font size, you're still going to need glasses for that, unfortunately. And yes?
I've got a question for you. So, Nick, we all use our cell phones a lot.
Yes.
And I know on my phone, I've got these settings like, do I want it to be light or do I want it to be dark?
Correct.
So, to help protect my eyes, is there a option that is one better than the other, or are they both the same as far as, the constant use on your, or barrage to your eye with the
That's a good question.
lens?
So there's no, in terms of, as far as we know, there's really no difference in terms of the light or dark version as to your eye. We think it's the blue light from the cell phone itself that causes changes in our brain.
Which comes through either way, whether you're
Correct.
on night mode or day. Yeah.
Exactly. So it doesn't really make much difference. One thing that I do tell people with screens that we're on, and you may all know this, is that when we're on these screens, we tend to blink less. So that is one of the reasons that our eyes are so dry these days, because we are focused on our phones, on our computers, and we're blinking less. Not only with computers, but even watching TV, even knitting, even things that entail a lot of concentration, we just tend to blink less, and that can dry out our eyes. So frequent breaks, we talk about this 20-20 rule with dry eyes, and we talk about just try to give your eyes a break every 20 minutes, close your eyes for 20 seconds, look at something far away for 20 seconds just to give your eyes a break if you're going to be on the computer a lot. Well, I really want to thank you all for coming. Awesome. Glad to hear it.